You're listening to the Pharmacy Podcast Network.
We have an aging population taking more medications than ever before. On this podcast, I will interview experts in geriatric medicine to gain insight so we can provide optimal care to patients in their golden years. I'm your host, Dr. Tamara Ruggles, and this is the Geriatric Pharmacy Focus. Hello, everyone, and welcome back to the Geriatric Pharmacy Focus. So today we're going to be talking about chronic itch because with my older adults, how many times have I seen them have chronic itch or a diagnosis of chronic itch? And what is thrown at them is an antihistamine. And so a couple years ago at the American Society of Consultant Pharmacists meeting, I went to a talk on chronic itch by Dr. Laura Meyer-Junco, and she titled it Itch Please. And it was so informative about chronic itch, the causes, the prevalence, the treatment, that I thought this would be a good thing to share because it's not talked about a lot, but it's prevalent in our older adults. And there's a wide variety of treatment options, and that's not always an antihistamine. So I would like to welcome our guest, Dr. Laura. She's a clinical pharmacist and assistant professor at the UIC College of Pharmacy in Rockford, Illinois. She's also the editor-in-chief of the Journal of Pain and Palliative Care Pharmacotherapy. And if you've been listening to this podcast when it was formerly the LTC Pharmacy Podcast, Scott and I had her on as a guest about a year ago on opioid stewardship, which is a great episode. So please tune in if you haven't to that episode. But welcome back to the podcast, Dr. Laura, and tell us what is new with you since we recorded a year ago.
Well, it's hard to believe it was a year ago. It feels a little bit longer since I'm a new mom and kind of, in the trenches with that. He's going to be 11 months next week. But professionally, something that's new that I'm excited about is a special issue of the journal is going to be released. It's the first one that I've been the editor for. And I think it's going to be an influential issue for many pharmacists that are trying to expand their toolkit, which is kind of the emphasis of today's talk, too, about expanding our toolkit beyond antihistamines. So this special issue is integrative approaches to pain and palliative care and going beyond pharmacotherapy. So I have invited commentaries from pharmacists and also non-pharmacists that are exploring integrative approaches and expanding our pharmacotherapy toolkit beyond drug therapy. So it's been a long time in coming to kind of get this polished off. We got one more article to get through production, and then it's going to be released. So new baby, new special issue.
Oh my goodness, that's exciting. Where can we find the special issue?
So it's for the Journal of Pain and Palliative Care Pharmacotherapy. I will be posting it on LinkedIn once it comes out. So it should be by the end of October, it will be released. So you can sign up to get the print issue or otherwise the electronic issue. So any editorial piece in the journal will be free access. The rest requires, some sort of electronic access or purchasing of the article. But I'm going to try to announce it, far and wide with all the work that went into that when it is released. But
that's going to be incredible. Yes, and if it's out when this episode drops, I'll put a link in the show notes so you guys can go purchase a copy. I'm sure it will be worth it. So, well, today we're going to talk about chronic itch. And so at your CE session, like I say, I just learned so much. I thought it would be valuable. So to start us off, tell us how chronic itch is diagnosed and how prevalent it is in our older adults.
So I think that's an important thing to distinguish when we're looking at our patients that, prescribed antihistamine or dealing with pruritus is kind of distinguishing whether this is acute pruritus or chronic pruritus. And it seems kind of arbitrary, but it's a 6-week marker. So if it's less than 6 weeks, it's considered acute. And acute pruritus could be histamine mediated. But then when it's chronic, and so meaning greater than 6 weeks, it's likely not histamine mediated, yet we're still throwing antihistamines at these folks. And so chronic itch is actually highly prevalent in older adults because of skin changes in the skin as they age, and also age-related changes, but also disease, accumulation of disease like neuropathic conditions. So it's thought that this different depending on what literature you look at. But so older adults who are greater than 65, it's thought that maybe 50% of them have chronic pruritus at some point in their life. And then 1/3 of nursing home patients will have chronic pruritus. And then the weird thing, and this is really something that we often struggle with, is this chronic pruritus of unknown etiology. This is a refractory condition that we throw different agents at it, and it is just still there. And older adults are actually, the group with probably the greatest prevalence of chronic pruritus of unknown origin. So, we're kind of up a creek with our older adults and pruritus, and these figures are kind of a little eye-opening, I think.
Yeah, I mean, 50% will experience it in their lifetime. That's huge. And so, yeah, you kind of talked about those. Why does it increase with age? Well, our skin changes as we age. We have more chronic disease states. So several reasons why our older adults are so prone to that itching greater than 6 weeks or pruritus. So I feel like one of the areas that we can really provide value as pharmacists is identifying causes of itch, but especially identifying medication causes of chronic itch. Can you tell us some of those medications that cause itch?
So with the medications that can cause itch, if you look at published literature on it, and many of them are case reports, there is an astonishing number of medications that can cause itch. But kind of the two largest kind of etiologies of why medications would cause itch is due to drug hypersensitivity reaction. So you're thinking antibiotics or antimicrobials. There could be an allergic response to that, which would then cause skin changes. And another large reason why certain medications may cause itching is due to cholestatic liver injury. So cholestatic disease of the liver is also a major cause of chronic itching. And so drugs that may cause or contribute to injury to the liver, such as, amiodarone or other medications, so sometimes even antibiotics can cause cholestatic liver injury, then that could cause itching. And then some other medications that may have another mechanism for itching would be like ACE inhibitors because of increased levels of bradykinin. And then the major category of medications that I think about that cause itching are opioids. Okay, so opioids have actually two mechanisms that can cause itching, a peripheral and central. And that's actually kind of funny because when you look at various chronic diseases that can cause itching, they also have a central plus peripheral mechanisms. So we often think that opioids cause itching through a peripheral mechanism with release of histamine. That may be the case for some opioids like morphine and codeine, but then why does fentanyl cause itching, especially when given as a spinal fentanyl? Why does that cause itching when it doesn't actually cause histamine release? So the major mechanism of opioid-mediated itching is through mu-opioid receptor and kappa receptor imbalance. And that's also thought to be the mechanism behind, a central mechanism behind pruritus due to cholestasis. So it's challenging to figure out what medications may be contributing, and many of them could be according to case reports, and that's kind of the literature quality that we're dealing with. So kind of doing a good medication history and kind of using the temporal relationship between when the itching developed and maybe when a new medication was started. But it can be very challenging. But that's why pharmacists need to be involved to kind of do the detective work on this.
Yeah, I can see, how that could be challenging because think of how many of our older adults have chronic itch, but also chronic pain. I mean, yes. You see it all the time that they're on some sort of opioid for chronic pain, and also ACE inhibitors are so common too. So plus the itching. So I can see how it would be, yes, detective work to go back and see when did the itch start? When did the medication start? And is it frequent that the medication would be started and then the itch would start soon after?
That's a good question because, if you're talking about hypersensitivity reactions, they can be acute and delayed. So it can be challenging to find the temporal relationship. But if it is a medication that could be deprescribed, then do a trial deprescribing and see if itch improves. But I think even a larger factor beyond just medications in older adults that contributes to itch that we should address all the time is dry skin, right? So that's why sometimes you'll see like literature suggesting that diuretics and volume depleters can cause itching. And I wonder, is it something related to the medication itself, or is it just through dehydration, right? And then the whole ball of wax with a dehydrated individual, dehydrated skin, etc. So it snowballs pretty quickly. So I guess I don't have an exact answer in terms of when the itching develops. With opioids, it would develop acutely. So at least there's an easier temporal relationship there.
Okay, well, that's helpful. So that is helpful, I think. With chronic itch, it's not histamine. It could be medications. What are some other causes of the chronic itching?
So when you're thinking about chronic itch, I think the first thing that you want to decide is whether it's occurring on inflamed skin or non-inflamed skin. And that can be difficult if you're not having a face-to-face assessment with a patient, but also because people scratch and then the skin does get altered and does get inflamed. But beyond the acute and chronic, it's important to know what the skin looked like, at the time the itching began, because if it was chronic itching, but the skin has been inflamed, then that's likely some sort of dermatological condition that needs to be managed with specialty care, immunomodulators, biologics, etc. So getting a referral to dermatology. Now, if the itching is chronic and is occurring on non-inflamed skin, then we have things that could be happening centrally. So one such category is called neurogenic, which basically means the origin of the itching is probably primarily central, though there could be some peripheral processing also, but it's not due to any damage to the nervous system. So it's neurogenic, so due to the accumulation of, endogenous substances that accumulate and cause changes to the endogenous opioid system, endogenous serotonin system, you name it, that then propagates this chronic itch. And then another cause of itch that could be a cause of chronic non-inflamed skin itch is a neuropathic. So due to, peripheral diabetic neuropathy, there can be, a localized itch on non-inflamed skin. Distinguishing between localized and generalized is also helpful, not only for etiology, but also for our treatments. So even for neurogenic types of chronic pruritus, it tends to be more generalized. So neurogenic conditions that would cause neurogenic pruritus would be like end-stage renal disease, where you're getting the accumulation of uremic toxins, etc., and probably some changes also to sensitization of the nervous system. In CKD, it's generally a generalized pruritus, but they can sometimes have localized itching, like on the upper back where the skin is not inflamed. And then you have cholestatic pruritus, and then that is also generalized, but sometimes can be localized to the palms of the hands. So I guess there's chronic, you're thinking more systemic disease and accumulation of endogenous substances due to, organ failure. So, liver, renal. And then you're also looking at, could there be a peripheral neuropathy that is causing a localized itch where the skin doesn't look like it's having a inflammation. And then the last cause is psychogenic. And I think we need to appreciate that this could occur. And it's usually a diagnosis of exclusion, where it's not neurogenic, it's not neuropathic, it's not originating in the skin, which would be like a more cutaneous cause, then it could be psychogenic. So, which does occur, and sometimes using an SSRI can be helpful in those cases.
Okay, so there's lots of different causes. Mm-hmm. And I remember at your talk at ASCP, there is ways to manage each cause individually, but there's also one thing we can do for all patients with chronic itch. So first, let's start with what can we do for all our patients who have chronic itch regardless of the cause?
Yeah, so that's good that you brought that up, because the discussion that we just had kind of makes your brain itch. And it's kind of overwhelming, but it's helpful to know there's like a common pathway in the peripheral pathway for many of these different conditions that cause itch. And so it's the peripheral propagation of itch. There's a histaminergic pathway and then there's a non-histaminergic pathway. And regardless of recognizing whether histamine's involved or not, a common receptor to both of those pathways is the TRP receptor. And so whether we think this is mediated by histamine it's inflamed skin, it's an acute process, or it's maybe a chronic condition that's neurogenic with some peripheral involvement. Regardless of knowing those nuances, the histaminergic peripheral pathway and the non-histaminergic peripheral pathway share the need for this signal, this itchy signal, to go through the TRP receptor, and then the TRP receptor causes an action potential through sodium channels. So there is common pathways and commonalities to both of those. And so why this is important, because using something that causes a cooling sensation like menthol or putting lotion in the refrigerator would activate the TRP M8 receptor, which would be common to both of those pathways. So then that could actually reduce the itchy sensation. So that's regardless of whether we're talking, neurogenic with a central pathway, but also peripheral mediators also, or we're talking about itchy histamine mediated, sunburn itch, that the TRP receptor and the sodium channels are going to be common to both of those pathways. So using something that activates the TRP receptor in a cooling sensation way, so menthol or lotion that's cooled. And then also to block the sodium channel, you could use a local anesthetic like lidocaine. You got to be careful with that if the itch, in fact, is more generalized, because you don't want to bathe in this local anesthetic. But another thing is dry skin. So dry skin, regardless of the cause, will exacerbate itching. So another thing that happens in older adults is that the skin may have like a greater alkaline pH, and that greater alkaline pH actually can activate proteases, which then activate the non-histaminergic pathway. And then also kind of snowballed in with this alkaline pH and this changes of the skin is dry skin. So kind of both of those together can kind of activate the non-histaminergic peripheral pathway. So using emollients and keeping the skin moisturized is something that you should do for all patients, regardless of what the cause of the itch might be. So we have some tools that we can use. So lotion, refrigerated lotion would probably be a common pathway for everybody.
Yeah, I'm glad you brought that up, because I've used that since I'm going to your talk for my own kids. Like if they have, I don't know, if their leg is itchy or something, I'll just put an ice pack on it, like cool it off, Mm-hmm. Or I have told several of my nursing facilities for patients with chronic itch, they might have Eucerin lotion ordered, and I'll say, keep it in the fridge. And then when you put it on there, that can help soothe the itch along with the lotion. So I've used that a bunch since attending your talk, and it really does work. The cooling definitely helps the itch. And it does seem like the warmer the room, I don't know if that's also a thing, but my patients who have really warm rooms, it does seem to exacerbate that itching a little bit. So I tell them, maybe their room is warm and that's making the itch worse. If you try the cooling lotion, it'll help.
That is true. So if they keep a cool environment, that will help with the itch, because warmth does worsen itch. And that's why, even though capsaicin also works on the TRP receptor, and that's the commonality between both of those pathways, I don't often recommend capsaicin, because even though it may work with repeated applications, because also substance P is in there too, it can cause a little warmth, and that can actually make itch worse kind of in the beginning of trying to use capsaicin. So definitely something with the temperature. So cool environments, cool lotion, ice packs, especially when you have nerve impingement that causes the itching. Actually, ice packs are supposed to be very helpful. And I kind of love that idea about sharing this information that's non-pharmacological with nurses. Kind of ties into the special issue I'm putting out there, that I really think it's important that pharmacists know non-pharmacological strategies, because there are limitations to our drug therapy, and so it's like, and nurses love it. Our other disciplines love it when we're able to use something that's also in their wheelhouse. So I'm glad that you're using that, because I was pretty excited. The nurses are excited about that. The nurses that I work with are excited about that tip, but I also am pretty excited about that tip, because non-pharmacological, and I'm expanding my horizons beyond drug therapy.
Yep. And nurses are so amazing at treating our patients. And so it's nice if you can give them like a general recommendation that can help many different patients. So I do love that about that tip as well. Okay. So for all of our patients with itch, we can make sure that their skin is getting moistened some way, and also the cooling. So let's talk about each category and maybe like some treatment options for that category. So you started with neurogenic causes like chronic kidney disease, what are some treatment options for the folks who have neurogenic itching?
Okay, so for neurogenic itching due to end-stage renal disease, it's going to be, you're going to see these patients that have probably already been pre-treated with an antihistamine and it didn't do anything. They're probably going to come to you with a lot of different failed therapies, and that's because in CKD in advanced stages, so either they're CKD5 or CKD4, not yet on dialysis, the mechanism of the pruritus is central usually. So it's due to central changes so almost like a neuropathic change in the handling of the nervous system. There's often peripheral mediators that accumulate also, like uremic toxins. There can be accumulation of calcium and phosphorus. So there's many things that are at play that are not mediated by histamine. So some, kind of supportive measures you can do is make sure if they're still eating food that they're taking phosphate binders so that they can decrease that calcium phos product that they have that would accumulate these divalent ions in the skin, which can cause itching. And then beyond that, beyond optimizing dialysis treatments and that type of thing, is we'd be using gabapentinoids. So gabapentin and pregabalin have evidence for use in reducing pruritus due to advanced kidney impairment. And that's because it's likely some sort of central sensitization that occurs. So there's changes when there is continuous input of information to the spinal cord, kind of like in pain over time, and then there's some windup. So gabapentinoids work very well. And so gabapentin probably has a little bit more evidence behind it than pregabalin, but kind of fair game for either of those. So gabapentin being a little cheaper is probably the way to go. But you just have to be careful with your dosing, right? Because this is a renally dosed drug. It's going to accumulate in patients that have poor renal impairment. And also removed by dialysis too. So you have to think about timing it at bedtime. So generally the dose is 100 to up to 300, 3 times weekly. And then following in the evening hours, so after dialysis. And I started on 100 3 times a week, 100 milligrams 3 times a week, and following after dialysis time, and then titrate up based on response. And so then the pregabalin dosing would be similar to a dialysis dosing of pregabalin. And that actually tends to be very effective for pruritus due to end-stage renal disease. Now, sometimes we try to do an indication creep with gabapentin, and sometimes we try it in other itchy conditions where it doesn't work. So you really need to be mindful of where we're using it. So the greatest evidence is for end-stage renal disease patients that have chronic pruritus. Now, when you have this chronic pruritus of unknown origin that's been refractory and it's ongoing for years, there could be some central sensitization in the nervous system, regardless of whether the patient has end-stage renal disease, for which the gabapentin would be worthwhile trying and could be helpful. So kind of be aware of that, because I think there can be some knowledge that gabapentin is helpful in itching. And so sometimes I see gabapentin creeping over for uses in non-neurogenic, non-central sensitization type itch, which is probably not where it belongs. And then when you think about cholestatic liver disease, the mechanism is thought to be central and peripheral, just kind of like end-stage renal disease is. And so the central mechanism is due to imbalance of the mu-opioid activity and the kappa activity. And so you'll see things used like naltrexone for this cholestatic itch to kind of antagonize the mu receptors and kind of restore that balance. But you got to be careful with that, because if they also need opioid therapy, that's not going to work. And there's GI side effects of it, and also worsening liver disease. And then the peripheral mechanism that you could target with cholestatic liver disease would be like a bile acid sequestrant. And that's probably usually where I would start before throwing naltrexone at a patient. Would be like a bile acid sequestrant, like cholestyramine, or sometimes cholestyramine is better tolerated. So you're kind of having to go. As you can see that nowhere in there I discuss antihistamines, because they don't play a role. These are not histamine mediated. So you have to think about targeting a central pathway that doesn't involve any histamine modulation. So it's kind of, a little bit of a paradigm shift, but when you figure it out, it's the patients are and the families are very much thankful, because pruritus and chronic pruritus could be as agonizing as pain, according to some literature and to some patients. So
Yeah, I have seen it where it just really affects the patient's quality of life. And then they itch so much, they get skin breakdown, and then they get at risk for cellulitis, and then all sorts of, and you really got to keep up on nail care and just, skin checks and things like that for your patients with chronic itch to prevent those infections. But it really does affect their quality of life, and it is bothersome for these patients. And so that helps us with the neurogenic and the cholestatic causes. So let's talk about then the neuropathic, those peripheral neuropathy, those kind of causes of itch, and how we treat those.
So generally, when you're thinking about neuropathic causes, it's usually peripheral neuropathy. There can be central neuropathies that cause itch, like, multiple sclerosis, and that type of condition can cause a neuropathic central mediated itch, but it's really rare. So usually you're thinking peripheral. So you're thinking about people that have post-herpetic itch following shingles, or people with peripheral diabetes. With peripheral diabetic neuropathy, we'll also have pain, the stereotypical neuropathic pain, but also some itch associated with it. And so how those are managed are similar how you would manage neuropathic pain. So using a gabapentinoid. You also could think about using the things that we've already previously talked about, like the medications that work at the TRP receptor, like menthol, and also your local anesthetics, because this is most of the time in peripheral neuropathy, it's going to be localized. So then you can localize itching, so you can get away with using anesthetics without having to apply it all over, which would be problematic. So you kind of think about there's quite a bit of similarities sometimes in the processing of itch and pain. And so that's why even some of the language that you use, you have nociception, which is normal pain processing. And then for itch, it's like purioception. So it's actually kind of some overlap there in terms of the mechanism. And then in the agents that we use. Yeah.
So for the lidocaine, for the neuropathic pain, do you use like a topical gel or a cream, or are you talking about the lidocaine patches?
So that's a good question. So generally, I would say a cream, but then you think about if it is something localized and in an area where a patch would be amendable to using a patch, then I would probably prefer the patch, because if you think about it, if it's a cream, you're going to have to apply it very frequently, and that might not be practical. So using anything that is a topical anesthetic, and so lidocaine in a patch form is topical and not transdermal. So yes, you could use, I'm glad that you brought that up, because people probably are thinking cream, but you also could use a patch if the area of itch makes sense for using a patch.
Okay, great. I really like the patches, lidocaine patches for my older adults who have like a localized pain, because you don't get the side effects of the opioids, and then they're over the counter now, which is really nice, because before no insurance companies would even, pay for them. So you're trying to do prior auths all the time, but now that they're available over the counter, it makes it really.
Oh, it's a game changer with the diclofenac gel too. Yeah,
absolutely. Okay, so the last cause here we haven't talked about is that psychogenic causes of chronic itch, which is that diagnosis of exclusion, probably. But how do we treat that?
So that tends to be similar to how you would manage other, psychiatric issues, is using your psychopharmacotherapy. So SSRIs. And I kind of like the idea of using sertraline, because if you look at some of the other literature for neurogenic causes with generalized itch, sertraline also plays a role. It can play a role in, due to itching due to end-stage renal disease or cholestatic liver disease, and also psychogenic. So in case maybe you miss some other underlying cause, then that SSRI, particularly sertraline, would be the go-to. So that's probably how I would manage it. If it's safe to initiate a SSRI in that particular individual, you might have to use redirecting or distraction or something of that nature. But again, it could also feel good to use lotion that's been cooled, and that could maybe be helpful for the psychogenic itch also. So a lot of our tools kind of go across the continuum, and we're not really talking about antihistamines. Now, I don't want to say we can't ever use an antihistamine if it has the histamine, the wheal and flare reaction, and it's inflamed skin, and it's very clearly due to an acute issue. So a sunburn, a drug hypersensitivity, an insect bite, hives. It's either acute, sometimes you get acute and chronic hives, and those conditions are definitely responsive to antihistamines. So not completely voted off the island, but if you're going to do an antihistamine, you can actually use second generation antihistamines. They are thought to have equal efficacy to a first generation. So there's no reason you'd have to do diphenhydramine. You could definitely do second generation. And my preference kind of is for cetirizine, because I can pull out this study that showed that cetirizine actually was equivalent to hydroxyzine in a study of acute itch, which is good because a lot of the folks I work with assume for some reason that hydroxyzine is like where you go to after Benadryl doesn't work. And I'm like, no, no, not necessarily. You can even use cetirizine, which would have similar efficacy to hydroxyzine with lesser side effect burden. So
yeah, I like that because I agree with you. A lot of my providers also seem to go toward hydroxyzine, and it really does make my patients tired. They're just sleepy during the day when they're on it. So I like the idea of cetirizine better myself too. So you're saying if it's mediated by histamine, you would see something on the skin that would show it would be mediated by histamine probably.
Generally, the skin would be inflamed, and it's tricky because, like you said, people are scratching, they're getting secondary infections, and it's hard to tell. But generally, it should have the traditional histamine, flare, and wheal type of hive-looking picture that would be suggestive of a histamine-mediated pathway. So then some people say, well, the Benadryl worked, and we didn't see any of the skin changes that you're talking about. Well, the Benadryl probably worked. If it worked and there wasn't this traditional histamine reaction, it worked through sedation. And so that's where, it's sometimes like, yeah, I know it works, but that's not necessarily the reason I want it to work, because any symptom will be somewhat suppressed through sedation. If you have less conscious awareness of an itch, of a nausea, of pain, that through sedation, then symptoms will be relieved, but that might not necessarily be the way we want to do it. Maybe reserving it for bedtime use if it really disturbs sleep, but you will sometimes see that, the antihistamine did work, but it was probably through sedation. So if you really want to know if it's really antihistamine mediated, then use something that doesn't have any sedation potential like loratadine. And if it didn't work, then it wasn't histamine mediated. So, and cetirizine has a little bit of blood-brain barrier penetration, so maybe a little bit of sedation. So that way you kind of get a little best of both worlds. There's some sleepiness maybe, and then the antihistamine effect. So it's
That's
tricky.
a pro tip.
Buy-in. Yeah.
That's a pro tip right there. I like that because when I do have patients on hydroxyzine and they say it helped, I've always wondered, like, well, is it helping because of the sedation or the antihistamine? But I like that. Switch them to a loratadine or a non-sedating antihistamine, see if it's still working. And if you switch them and it's not working anymore, it's from the sedation and not the antihistamine effects.
Yes.
I like that. Okay. So I do have one more question about gabapentin because, I do think it can be really helpful for chronic itch. So when you start them off at the 100 milligrams 3 times a week after dialysis, how long do you give it to be effective? And at that point, do you increase the dose if it's not effective? Or do you say, at what point do you say gabapentin is not going to work for your itch? Let's stop it.
So that's a really good question because we think about in pain that we usually have to, or not usually, we always have to titrate to a range between 900, but generally 1800 milligrams to the max dose of 3600 milligrams per day before we're seeing an improvement in pain. And that can take 2 months if you're diligent about it. Now we do tend to see an earlier response when we're using gabapentin for itch. And I think it's primarily because these patients have end-stage renal disease. And so we're kind of hitting target doses for acting on those calcium-mediated voltage-gated calcium channels. There we go, voltage-gated calcium channels. We're kind of getting where we need to go in terms of targeting those channels sooner because of the end-stage renal disease, if that makes sense. So there's kind of less of a titration response. And gabapentin, when you first initiate it, has the transient drowsiness that does improve over time. So there's a little bit of sedation, a little bit. That's why you dose it at bedtime. That probably gives us an increased perception that it's helpful with the patients early on while we kind of get to the dose that we need to go. So I usually say within 1 to 2 weeks, the gabapentin in my experience has been helpful, because we're thinking the target dose for actually acting on our voltage-gated calcium channels is much lower than if they had normal renal function. And then the sedative piece in there. So, but that should hopefully be transient. If it's persistent, then we need to do something about it, because then we have to ask ourselves, what is worse for the patient, the itch or not being able to engage with their family, and kind of reduce even further. Sometimes we've had patients just on 100 milligrams twice a week. So kind of working with, their preferences, itch versus daytime sleepiness. So yeah, that's a good question. And I don't have a great answer for you, except that I do see that the titration schedule is much tighter because our target doses are much, much lower.
Yeah, that is helpful. Because I agree, sometimes when you use gabapentin for pain, it feels like it takes forever to get to that target dose. But if the target dose is small and you see an effect in 1 to 2 weeks, that's great.
Mm-hmm.
Okay, so for a pharmacist who want to learn more on this topic and who want some good resources for their patients that have chronic pruritus, where would you recommend they go to look?
So that someone needs to write a book for us, because when I put together this presentation, it was really, really hard to get resources together that was just all in one place. So I really kind of struggled with that in terms of finding a good resource. So I would say there are a few textbooks that are a little bit older that I think do put it together completely. It didn't have a lot of the mechanism pieces that I wanted, so I had to go elsewhere and look at some journal articles for that. But it's from Oxford. So sometimes Oxford Publishing publishes little mini books on various topics related to palliation. And so they have a book called Pruritus in Advanced Disease, and it's from 2004. So it's a little bit dated, but we really haven't gone very far. So there might be a little bit less discussion of the gabapentinoids, but I still believe it's in there in some way. So that textbook is helpful. I actually got this other book. It was called Pruritus from Springer, and it was very detailed, very technical, very, this mediator does this. So I don't necessarily recommend that unless you're really trying to go home and draw out the pathways for pruritus. Other books that could be helpful, resources, the Palliative Care Consultant book, which is, for hospice and palliative care. It does have a chapter on pruritus. But I would say to get it all in one place, all the information in one place, I haven't been super lucky. There is some, in terms of guidelines, we don't even really have American guidelines that are focused on pruritus. So I actually had to go to European guidelines, and they have several guidelines that are mostly focused on acute and chronic urticaria, or however you say it, hives. And that did have helpful information about the nuances with antihistamines. Another resource, if you want more information about antihistamines in general, I think the APHA book, the Non-Prescription Drug Handbook, I think that has recently been updated, was a good resource for that. But again, I had to piecemeal things to really put together a whole picture. So there's probably not one comprehensive resource. It's a bunch of pieces together. And then just your own clinical experience with it, because a lot of the literature isn't high quality, right? We're looking at case reports, retrospective. So your own clinical experience is probably going to inform your practice too.
Yeah. And I feel like just learning from you and from talks like this, where, you have a patient come to the counter, or you see a patient in your facility and they're talking about itch, and you see it's been long-term, it can at least make you think, oh, maybe gabapentin, I should look into gabapentin for this. Or, is this psychogenic? Do they need to start? So at least gets you thinking about potential other causes. And if nothing else, put the lotion in the fridge and tell them to grab an ice pack, So just little things like that can always help pharmacists, expand our knowledge base and at least get us thinking in a direction that we hadn't thought to think before. So
exactly. Yep.
Well, this has been absolutely amazing. I always love learning from you, and I'm excited to learn from you again at the next ASCP conference coming up here. But in the meantime, where can people find you?
So at LinkedIn, I'm on LinkedIn. So if you want to touch base with me, LinkedIn would be the way to go, or maybe my editor email. So that's jppcp.editorinchief@gmail.com. But I would say probably the quickest way to get a hold of me is LinkedIn, because I do have the notifications on my phone. So I will get a notification and just search my name, and that's the easiest way to probably find me and find things that I'm doing currently. And if you want to collaborate on anything, I'm open to it. Geriatric, palliative care, always looking for new projects and new things to, expand my toolkit.
I love it. You're amazing. Thank you so much. And thank you, listeners. I appreciate you. Have a great day.